Hello, everybody. On behalf of the ICS Institute, it is a pleasure for me to invite you to this live webinar. We are going to discuss the management of neurogenic cases in this time of COVID-19 pandemic. Today, we have chosen a case of multiple sclerosis. I am Rizwan Hamid, Director of the School of Neurourology, and I have with me Emre Huri from Turkey.
Good afternoon, everybody. I am Emre Huri from Ankara. I am the Director of International Continence Society, School of Modern Technology. On behalf of the School of Modern Technology, it's a great pleasure to be a part of this project, and I wish you a useful and successful meeting.
So, hi again. As we mentioned, we are going to discuss a case of multiple sclerosis and how we can manage these cases at the time of this crisis. So this is a typical 43-year-old female who's got multiple sclerosis for about 10 years now. She's got bladder symptoms, which are symptoms of overactive bladder, including urgency incontinence, and occasional episodes of cystitis. So I would like to ask Emre, what would be the aims of treatment in these circumstances, in this case?
Actually, we know that as this case, the most frequent symptom in multiple sclerosis patients is in 60 to 80% the feeling symptoms and the neurogenic detrusor overactivity that may cause a high pressure bladder. So the first aim is the protection of upper urinary tract. So we should know that the important issue to provide the good bladder function. Another important issue is the improvement of the urinary continence. And the third is the relatively with the previous two ones, the improvement of the patient's of quality of life. Of course, one of the essential aim can be the restoration of normal lower urinary tract function.
That's brilliant. So that is as part of the EAU guidelines. In the United Kingdom, we have got an MS algorithm, which Claire Fowler published more than 10 years ago. And it's a very simplified algorithm, which is ideal for nowadays application. And essentially, if somebody has got symptoms of overactive bladder, we test and rule out infection and check what the post-void residue is. Emre, I know there is some contention about less than 100 mils of post-void residue. So what are your thoughts on that?
Rizwan, actually, this is a very good point for that because the PVR value is very important, especially for detrusor undercontractility on the detrusor sphincter dyssynergy patient. And it's not too many, but the 20 or 25% within the patient. And we know that the cutoff level of the 100%, 100 cc for CIC is not a certain value. It can be variable and different point based on the patient clinical situation, the bladder capacity.
I completely agree. I think it should be patient dependent, but one way or the other, I think in this time of crisis, anybody who's got symptoms of overactive bladder, the initial management of controlling of the overactivity with medications, be it anticholinergics or mirabegron, or instituting them on self-intermittent catheterization, probably should be our aim. And our goal should be that the patients should be managed with the symptoms of overactive bladder and incontinence by these two simple measures for which they don't need to come to the hospital. However, we do know that a proportion of patients would not be controlled, or their symptoms will not be controlled on this management, and we need to go to the next step. And Emre, you think we should be doing urodynamics in these cases?
I agree with you, Rizwan. We have to do urodynamic cases routinely, but of course, in this situation of in the pandemic, so we should postpone the cases with the controlled postponement can be suitable for that.
Yeah, I think you're very right. And Chris Harding, one of my colleagues from Newcastle in England, has asked exactly the same question, that in these cases, how do we make sure that their bladders are safe and not dangerous? And I think, like you said, that we would normally do urodynamics, but here, because we can't do urodynamics, so we have to rely on the clinical symptoms like spasticity, their incontinence, what are the other features which are suggestive of upper tract damage or recurrent infections, and treat them in that fashion. But if we are able to do urodynamics, and this is just a picture to show, this is a classical overactivity, which I think we can see here. So it's quite a lot of overactivity. And that be the case under what will be a normal circumstances when we are not having this pandemic. We'll treat these patients with this ICI algorithm, which is brilliant. And in the bottom right-hand corner, you can see we can treat them with botulinum toxin injections. However, we know that at this time of crisis, this is something which we cannot offer by and large. However, one of my other colleagues from Toronto, Professor Magdi Hasuna, has raised this point that in his department, they are allowed to do botulinum toxin injections under local anesthesia as an outpatient. But to be honest, in the United Kingdom and of the European colleagues I have spoken to, none of us is offering botulinum toxin at the moment. So what's happening in Turkey, Emre?
In Turkey, the same with UK, and we postponed all botulinum toxin injection. So also the guidelines and the expert opinion, and also in my opinion that although you will do the procedure of intravesical botulinum toxin injection with local anesthesia, you need the closed system. It means that you have to protect urine within the closed system, because we know that according to the reports, 6 to 7% of the virus load can be found in the urine. So this is important point I would like to stress.
I agree. So in this time of crisis, the challenges we have got is that this COVID-19 has put an enormous pressure on our not only professional but personal lives also. But quite rightly, like you point out, that we have to look after the patient's existing conditions, but additionally, like you pointed out, that a proportion of them might be COVID positive. So would you like to take on and explain how the modern technology can help us in this regard?
Rizwan, first of all, as an healthcare professionals, not only the urologist, we have to take into account the COVID-19 pandemic and the clinical symptomatology. In this period that an infected person can be an asymptomatic or mildly ill, and that they could transmit the virus to the people, to other people, and via droplets and our coughs and sneezes. So we have to be careful, especially the most common symptoms should be differentiated from the neurourology patient. The most common symptoms are fever, fatigue, dry cough, myalgia, and dyspnea for the COVID-19 patient. So this possible overlap of COVID-19 clinical syndrome with different conditions, especially complicated urinary tract infection and the urosepsis, and it should be recognized by us, by a healthcare professional. You can be the urologist, nurse, and everything should be, everyone should be careful on that. So the overlapping the clinical conditions, especially the patient has a fever, very important.
I think you are right, and one of our colleagues from Brazil, Marcio Everbeck, has just asked the same question, that if a patient who is self-catheterizing and presents with fever, what is the first investigation which we should do? And I think that initially we should try to rule out a urinary tract infection. That should be the first thing we should do. And if there has got a positive urine culture, then treat it with appropriate antibiotics. However, if the culture is negative and they've got fever, then obviously we are looking towards COVID-19 symptoms. And what do you think are the other challenges in this regard, Emre?
Okay. The other challenges in this regard, maybe we have to be careful in neurourology patient. The regular follow-up. We know that our regular neurourology patients needs every 3 to 6 months regular follow-up. So we have to be careful. We have to create a close relation. We are using the video call, phone call, and any other virtual clinics. The aim, the second one is the challenge can be to becoming a continent for these patients. And also we aim to provide the non-infected patient and completely sterile urine. So maybe I can say that especially if the patient has urinary tract infection with catheterized, also with using the video call system, we have to check the catheter and the type of the catheter, and if there is a need for the changing the catheter, and we have to advise the patient to apply the first step health center. Also, the upper urinary tract safety and the quality of life and the psychological, social, and also economical status of the patients of our in neurourology patients should be our main objective.
I completely agree, Emre. One of the points in the regular follow-up is one of a colleague from Cleveland Clinic, Professor Howard Goldman, is actually asking that this is all right for the time being, but we are, although not hoping, but expecting that this COVID-19 situation is probably going to go on for a good few months. In that case, what should be our strategy to deal with the patients who are deemed as high risk? And my answer to that would be that it will have to be individualized, that the patients who are having recurrent problems, i.e. infections, they might have an admission because of blocked catheter or in urosepsis. A very small subset of those patients will have to manage them proactively as we are doing now. But as a general rule for regular follow-up, we should try to avoid bringing these patients into hospitals as much as possible. And obviously use the modern technology, which I think you are going to tell us more after we discuss the urosepsis, which we have just touched upon at the moment.
Of course, Rizwan, I totally agree with you. However, the main complaint can be the fever, as I mentioned before. And all the physicians, as all the urologists, should be involved in the initial evaluation of patients presenting with fever without other symptoms of the COVID-19. And it also can be interpreted as urosepsis or a complicated urinary tract infection. The attribution of fever to urinary infection could be supported by the presence of the urological catheters that need to be checked by us. And so, to date, I think very important information for us, no certain direct impact of COVID-19 on urogenital tissues has been reported. But we know that the COVID-19 can be one of the syndrome, not only affected the respiratory syndrome. So this is, I think, the main message can be for us, we have to be careful. If the patient has a fever and we have to see need to see the patient, no touch, and we can omit the physical examination. And the detailed history is very important. And also the lab tests, and including the urine and blood, and the radiologic evaluation can be done if we will for this priority high patient. Of course, we need to check the urethral catheters if the patient has a suprapubic catheters. Of course, we have to understand, differentiate the asymptomatic bacteriuria or any clinical infected patient. And also evaluation of ongoing medication is important. I just looked at one of the comments asked to some tests that will help us for differentiate the urinary tract infection or urosepsis from the COVID-19. And we can suggest, according to the guidelines and according to one of the paper coming from Italy, the procalcitonin level is crucial. And these levels are only moderately and no increase in the case of the viral infection. And also urine analysis, and also the complete blood count, and it shows the lymphopenia and the prolonged prothrombin time and the elevated lactate dehydrogenase are typical of COVID-19. So as an healthcare practitioner, we have to check these tests, especially for the problematic patients in neurourology patient. On the other hand, Rizwan, also I would like to ask your opinion about the diagnosis. We know that some guidelines new reported by EAU as an expert opinion What do you think about the diagnosis that you can give some messages on that?
Um, Emre, the diagnosis of COVID-19 in neurogenic patients, obviously, like you pointed out, is quite complex. And I agree with the comments of one of our colleagues, Charalampos from Greece. He has made a good point that in the first instance, if we can do, then instead of doing a telephone consultation, if we can have a video link consultation so we can actually see the patient, which can help a lot in alleviating the anxiety of the patient, because quite a lot of these patients would like to have a face-to-face interaction. And then you can see the patient, they can show you if they have got a suprapubic catheter, if there's any problem around the tract, any cellulitis that can be checked. If there are any pressure sores, we can have a look at it. Some of the blood results can be transferred via electronic means if they can have a local ultrasound scan. So we can use all these modern technology, which I'm sure we're going to discuss in the next few slides, to aid us in, without seeing the patients physically, have as much as information, both electronically and by the video conference, so that we can treat the patients without the need for them to actually come to the hospital. So I think if we go to the next slide, and here is what you were alluding to earlier on about the EAU guidelines. So as part of the guidelines panel, what we have done is to, in a way, categorize them into four categories, from low priority to the emergency, and which can be for the diagnosis, like you said, and in the diagnosis, the things which, or the symptoms in which they are unlikely to come to any harm are as low priority and can be postponed for 6 months, which includes all routine follow-up. All of us agree that the neurogenic patients should have a lifelong follow-up with regular blood tests, scans, and urodynamics. But during this time of crisis, probably that can be postponed for at least 6 months or till the time we are over this crisis. However, there are certain symptoms within this which have to be taken as a high priority. One thing which you alluded to about the urosepsis, that's an absolute emergency, because we know that in this group of patients, if we delay treating the urosepsis, then it can have very serious consequences. The same can be said about either the renal impairment or the kidney stones. If they are present with that, then those things have to be tackled as an emergency. So in the diagnosis, what we have to do is the routine investigations can be postponed, but the symptoms of urosepsis or stones or renal impairment have to be tackled as an emergency. What are your thoughts about the treatment, Emre?
Rizwan, actually, before starting the treatment, I would like to say only one comment on that. I would like to stress, especially during this pandemic era, the detailed history is very important to get it with using the modern technological tools like on video call. So this is very important if we will see the patient as a first time. However, for the treatment policy, it depends on, of course, due to the patient's situation in a regular time. We will select the treatment modalities. It can be medical, invasive, and surgical procedures. And also the EAU, as an expert advice, suggested and divided the groups: low, intermediate, high, and the emergent cases. So especially the most of the surgical procedures postponed at least 6 months. Probably you will remember before 2 months ago, and also American College of Surgeons advised some surgical procedures and limited to 3 months. And now we will see that it prolonged as a 6 months. I think it can be one of the debate that we can talk on that. But for 6 months, for the low priority patients, and defer all surgical procedures if there is no emergency, and the adjustment to medications may be carried out via phone or via video consultation. And also urodynamic, as you stated, that should be postponed, and all elective surgical treatments should be postponed. But the important thing is the emergent case as a blocked catheter. So the blocked catheter approach is is our main emergent situation, especially for neurourology patient. If we will delay the treatment, there can be serious complications like autonomic dysreflexia. But especially instruction in catheter unblocking to patients, not only to the patients, but also to their relatives may be considered. And so this is maybe the more advantages of the video conference, video call system compared to phone call only. So you will see the face-to-face, and then the patient can show his situation and the catheter, and then you can irrigate, you can control the relatives, then the first of all, and then start with irrigation, and maybe if there is no solution, you can advise your patient to apply to the emergent situation.
Yeah. So, Emre, I would like to come back to the invasive treatment. So I just want to point out that although these are the guidelines which we are presenting on, which are from EAU, but these are to be tailored and adapted to the local circumstances. And I will go back to Professor Magdi Hassouna. He's again posted exactly saying the same thing, that they are under a lot of pressure from the hospital administration that these Botox cases should continue. And they are doing these cases under local anesthesia to decrease the aerosol generation procedures, but they are doing it with full PPE protection. But I think the general advice is that we should try to avoid doing these cases, but obviously it has to be tailored according to what the local guidelines, local procedures are. And I would just come back to your thoughts about the blocked catheter. I completely agree. I think this is an absolute emergency in a neurogenic patient, especially somebody with spinal cord injury, because they can develop autonomic dysreflexia, which is a life-threatening complication. So I think that is a really serious life-threatening situation which needs to be dealt with. So now, if we come to the follow-up, again, I think we all agree as part of the neurogenic guidelines all around the world that these patients should have a lifelong follow-up. The follow-up time is different in different countries and different guidelines, but generally we try to see them once a year or once in 18 months. But we all agree that during this time of crisis, the hospital presentations or coming to the hospital for these patients should be as minimized as possible. So what we should do during this time is to hold regular telephone clinics so that the patients do not feel that that contact has been lost, and then we can pick up any emergency symptoms which are there, like you said, about developing a fever or a blocked catheter or any other significant symptom. For those are the only patients who then should come for the follow-up. Then I'd like to go back to the point raised by Professor Howard Goldman from Cleveland Clinic, that it is all right now, but what do we do if the situation continues for a little while, and especially as what we are now hearing is that for the vulnerable group and the elderly, probably these restrictions will be there for some time. So our advice should be that we need to do this on an individualized basis, and that very small subset of patients who have got low compliance, very high pressure bladder or renal impairment should possibly will have to be followed up much closely with a combination of telephone clinics, video clinics, regular bloods, maybe an ultrasound scan, and treat any emergency condition which comes up. So how telemedicine, Emre, can help us achieve our objectives under these circumstances?
Rizwan, actually, the telemedicine is a very useful tool. And I can say that the increase the awareness of the telemedicine, especially in the COVID-19 pandemic. So this is not new now. So probably there is a history of at least 5 or 10 years. But in telemedicine, especially within the guidelines as an expert advice, especially can be used to detect the urinary tract infection symptoms for uncomplicated And as many uncomplicated urinary tract infection, we know that will self-resolve within a short time or without appropriate antimicrobial treatment. And it's recommended in the guidelines. And just use the telemedicine or video conferencing or voice call and interview with the patient and to learn the situation of the patient. So if there is a fever, if the lower urinary tract symptoms increase, like a dysuria or any other decreasing the quality of life, of course, the main step should be the urine analysis, and we can advise the patient to apply for one of the can be COVID-free hospital. You know, we know that in some hospitals it's still working as a COVID-free hospital. So this is the, I think, important issue for that. But I would like to say another thing about the telemedicine. The telehealth is bridging the gap between the people, physicians, and the health systems. So enabling everyone, especially symptomatic patients, to stay at home and communicate with physicians. So by the way, you will secure your patient, helping to reduce the spread of the virus to the mass population. So it does not mean only to defer the treatment, neurourology patient, but also protect the other community with this, the increasing, the spreading the virus into the community. And I would like to say only one report from United States. Before the crisis, in alone, only 82% of consumers do not use such services, and in the global, and it increased the tenfold more compared to previous the crisis. So this is the, I think, main important, not only for neurourology patients, but today our topic is the neurourology, but also that the other consultation is now useful.
So and what is this health chatbot?
Actually, the health chatbot is a type of the artificial intelligence system. And however, we can advise our patient, especially to increase the more awareness of the situation and to motivate them, not only to go and stay at your bed and to motivate them to fight with the crisis. The chatbot system is an important in terms of getting information about the patient's own situation, COVID or non-COVID. So the following some vital values and directing the patient correctly, Rizwan. So this helps our patients easily. And I know that if the patient has a smartphone, there are lots of right certified health chatbot system that will help for our patients.
I think this is very important, and I think probably all of us should try to incorporate this health chatbot in our system so that the patients feel assured that they are in contact with the physicians. And what about the artificial intelligence? I think you have something to say about that also. I think that can also play a big part, not only nowadays, but going forward into our treatment pathways and algorithms.
Actually, Rizwan, this is the new way, and now this is the new not only for us, for world, and we know that with the crisis, the COVID-19 outbreak, the importance of the artificial intelligence-based applications increased the popularity, and we need to advise our patient for using such an applications for prevention and the follow-up for COVID-19. And increase the awareness of our patients for COVID-19 outbreak with using like a fast track system or corona check system. And we know that there is some publication on artificial intelligence system that can be useful especially in neurourology or also in functional urology patients, especially that can allow us to make a data and to simulate to giving the right predictability of the future of your health. On the other hand, everybody, all of us, and as a healthcare professional, can be worked as also the physician that have to be fight with COVID-19 when we see the patient, also in neurourology clinic. So we need to protect ourselves. Also, we need to make a differential diagnosis for COVID-19 with using the artificial intelligence. So to give instruction to also the relatives, not only the patients are important. So in my opinion, for neurourology patients, contact with the neurologist and also as a urologist, and the contact with not only the patients, also with the relatives, with using to motivate them for artificial intelligence applications.
Excellent. So I think this is something for the future, but I think the COVID-19 probably has expedited this into our treatment algorithm, and probably we will be using these artificial intelligence pathways more and more in the coming months and years. I think you wanted to highlight the protection, and we as healthcare physicians must take the steps to protect ourselves, not only for our health, but also in case that if the health care force becomes unwell, then they cannot look after the population at large. So you want to say some few points on this slide?
Rizwan, actually, I would put the protection because the protection of healthcare professional, it means that the protection of our patients. And of course, we have to protect us, and also we have to protect our patients. So, and we know that during this crisis, we had a bad experience on the medical devices, especially we know for neurourology patients, we can need more and more medical devices. Maybe it can be the one of the penile clamp can be, and also any other masks. So the 3D printed system can be very, very efficient for the protection, and also 3D printing system can be useful for some medical devices for our patients. And this, I think I would like to stress on that. Of course, the vaccine and drugs still on work, and maybe that can be for future, but I know that in my country, and still we were not applying the prophylactic drug administration, so it's not recommended that. However, I would like to ask one question, if you permit me, please. What about the telemedicine? What is the role of the health system in UK in telemedicine, and is there any restricted part of the telemedicine? What do you think about that, Rizwan?
It is coming to the forefront more and more during this crisis. Obviously, one of the things with telemedicine we have to ensure is to use secure networks. I think that's a huge challenge to make sure, because the patient information and data can be transferred, and we have to absolutely make certain that that is protected and encrypted at both ends. That is one of the challenges which we are facing, but we are trying as a government, the local and the NHS, trying to make sure that those systems are in place so that the patient information only goes to the patient, to the physicians, the GPs, and only the persons who are entitled and authorized to receive it. So I think that is proving to be a challenge. So, and that is why at the moment we are doing mainly the telephone consultations, and the video consultations and the use of other armamentarians of the telemedicines are just being refined. And we hope that we'll be using that in the future more and more. But at the moment, because of the data protection, that is somewhat restricted, because it comes to your next point of medical legal issues. Obviously, we want to treat our patients, but what we don't want is that information to fall into wrong hands and people start using it for other purposes. So that is very important aspect, which I think we should highlight during this webinar, is that we want to move at a quick pace to help the patients to have consultation with them, but also what we don't want is to open this Pandora box of the information, which is very, very sensitive in most cases, especially urological, to fall into public domain or into the wrong hands.
Yes, I agree. I think totally agree with you, Rizwan. It's very important actually to get an informed consent. If you are using the modern technology, such as telemedicine, such an artificial intelligence for decision-making process or diagnosis or treatment, I think we need to informed consent for the patient before we started using such an technological tools.
And what about the mental health of our urological patients? In the UK, more and more data, and we have got more and more surveys coming out that because of self-isolation, social distancing, and especially the vulnerable groups and the elderly, the incidence of mental health is rising more and more. So how you think what's happening in Turkey and generally over the world, and how can telemedicine and with modern technologies we can minimize patient falling victim to this mental health crisis during this time of crisis?
Rizwan, actually, you know that the International Continence Society really big and interdisciplinary society. So we have this is a big chance, I think. So that maybe we can go forward faster with on mental health, especially based on the cognitive function therapist. This is the main role of the cognitive functional therapist or occupational therapist for that. So of course, so actually. Not only the telemedicine, also.
Okay. So what do you think should be the futuristic foresight in neurourology?
Rizwan, the futuristic foresight in neurourology can be adapted also to widen. The first of all, the personal experience of healthcare professionals is very important, and please document it, and the trials should be published for our future perspective. The digital health will be more inside our neurourology after pandemic. So based on the diagnosis and the treatment. And I would like to also stress the big data and the AI-powered diagnostic follow-up schedule. So this is the importance of the data and the creation of data for our patient, especially such a lifelong therapy in neurourology patients. And also we know that the ambulatory monitoring also can be the futuristic foresight in neurourology, and also especially for 3D printing technology and product our devices for our patients. Only individual personalized devices can be a good option for that.
I think you're absolutely right. I think there's a lot of controversy on lots of things which is happening nowadays. But one thing which almost all of us, both in the medical world and outside in the politics and generally we all agree is that the life will not go back to how it was before the crisis. So within inverted commas, that normal will no longer be normal. And we'll have to use all these new technologies and new ways of living our life generally in the day-to-day basis, in health, traveling, politics, science, everything is going to change. And I think the modern technology with AI and all this telemedicine is going to play a huge part. We feel that here in the UK, probably we'll see more and more telephone consultations and video consultations. So, Emre, I would like to now conclude, and I think we know that the urological management in neurogenic patients has to be tailored to the individual circumstances. And this is even more pertinent during these uncertain times. And I think a set of these guidelines which we have discussed, both EAU, ICS, and other forums have actually come up. And I've just summarized them on this page that at the moment, we should cancel all face-to-face appointments. We should try to make as many telephone and video consultations as possible. All investigative procedures should be canceled. That includes urodynamics. And the surgical procedures should be postponed. Now, like botulinum toxin, only the emergencies like blocked catheters should be undertaken because there's a risk of autonomic dysreflexia. All of us will continue to provide care to our inpatients who have got neurological needs. But like answering to various questions which the colleagues have asked, that what's going to happen in the long term if this lockdown stays, then we'll have to have an individualized approach. And like some of our colleagues in Toronto, if they are carrying out botulinum toxin with the local protocols, we must ensure, like they are doing, to have a full PPE, and you have alluded that also in your discussion. Our main aim is to keep the patients safe and to keep them out of the hospital as much as possible, because most of our patients are high risk. And we have to follow the local protocols because different healthcare systems work differently, and also different countries are at the different points of pandemic. So everything has to be adjusted according to the local needs and resources, which probably is going to dictate a lot how we manage these symptoms. So are there any last words from you, Emre?
Thank you so much, Rizwan. I just read some comments, and maybe we can answer some of them. But probably we answered the most of them during the webinar, Rizwan.
I think so. I think, Emre, what we need to emphasize is that this is a very select cohort of patients who have got very extensive healthcare needs. During the time of what within inverted commas normality, they were looked after by a multidisciplinary group of patients, urologists, rehabilitation doctors, neurologists, nurses, OT specialists, specialist nurses. Now it is not possible for all of them to be involved in their care. And it is very important that we have got a link with them, either a video link or a audio, so that they know if they've got problem, who to contact, so they are not left out in the dark, as we say. And the other important aspect is that they should be assured that if they've got problems, which you have very nicely alluded to about blocked catheters and urosepsis, which are the two main ones, then they should have the confidence that if they have got problems, we can go to the hospital, we will get appropriate treatment in possibly, like you said, COVID-free atmosphere, so that they can have their emergency treated and then they go back to the community.
Actually, Ridwan, I totally agree with you, and I would like to add some comments on that. Remember that the neurourology patients and the most of the patient hasn't becoming as advancement as a slowly. So this crisis probably will be finalized, will be finished at that moment, maybe. But of course, the close communication with the patients with using the modern technology tools, and of course, some of them asking us what is the differences of the phone call compared to video call. And also, you mentioned that the video call is the face-to-face communication. And the second one, you can see whatever you can talk, and the last situation of also you can see any other devices for that. So I think we have to be more motivated. We have to continue our daily practice within using the modern technology tools and to increase the morale of our patients.
I think I agree, and some of the colleagues have sent very helpful comments around the same area that I think all of us agree that we have got these patients who have high-risk patients, they've got very complex needs. We should have a communication with them open at all times, so that our efforts should be to treat them in their local community as much as possible. But if they develop a condition which requires urgent attention, then we should be able to see them and treat them. And I think a number of colleagues, including Nicholas and Nina and others, have commented that we should try, if wherever possible, to treat these patients in non-COVID hospitals. All over the world, we have got the situation that some hospitals are treating more COVID patients, and some are, within inverted commas, we call it as cold hospitals. So these patients should be channeled to those hospitals so that they go there, have their problems sorted out, be it catheter, be it temperature or stones, and they can be discharged back into the community so that they remain safe out of COVID situation, but also they've got this reassurance that if they've got a problem, then that can be managed effectively. Any last words, Emre, before I close? We've got about 1.5 minutes.
I would like to say thank you, Rizwan. It was, I think, really nice, and probably we have lots of comments, so maybe we can reply afterward. Also, I would like to say to the audience for their participation, also for their comments. Thank you so much.
Well, thank you very much. And I think last but not the least, I'd like to thank the ICS office and Roger to host this. I think it's been very helpful. I think we'll have lots of comments, and hopefully we'll try to keep this going, because we do not know how long this crisis is going to last, no matter how everybody is eager for this to finish as soon as possible. So thank you very much to everybody. Everybody, please look after yourself, stay safe. Best of wishes to everybody and their families. Bye-bye. Thank you much. Thank you.
Thank you. Bye.